To Lifebridge Health's Facebook Live interview series. I'm Sharon Boston, and today we're coming to you live from the Sandra and Malcolm Berman Brain and Spine Institute. Today is March 26th, which is National Epilepsy Awareness Day. And joining to talk about epilepsy is neurologist and epilepsy specialist, Dr. Jay Foreman. Dr. Foreman, thank you for joining us.
Thank you for inviting me.
Before we get started, I want to remind our viewers, if you have a question for Dr. Foreman, please post in the comments section and remember to hit the subscribe button so you'll be notified each time we go live. So first of all, just a basic question. What is epilepsy?
So epilepsy is a common disorder. It's one of the most common serious neurologic disorders in which patients have recurrent seizures. Right? And these are unprovoked seizures. About 1 in 10 people will have a seizure in their lifetime. About one in 100 people will have unprovoked seizures that recur. When they have that, we call this epilepsy. Overall, what a seizure is an electrical discharge in the brain that results in a behavioral change in the patient. That behavioral change can be as simple as something like alteration of awareness, a little bit of speech problem, all the way to being completely unconscious and shaking and having convulsions.
Is the person aware of that themselves?
If it's a mild seizure, it's very restricted in one small part of the brain, we call it focal seizure, then yes, the patient may be aware. But if it spreads and goes to other areas, then it could slow functions, patients are typically unconscious, maybe altered. A lot of seizures begin in a part of the brain called the hippocampus and the temporal lobe, and these are structures that are involved in memory. And so for a lot of patients, when they have the seizure, it's kind of like taking an eraser to a chalkboard. They completely lose awareness of what's just happened, and they have no memory whatsoever for it.
And some people may have one seizure in their life and never have one again, or is it?
So as I said, 1 in 100 people, 1 in 10 people will have a seizure, but it's about 1 in 100 will go on to have recurrent seizures. And once we have evidence that you're going to have recurrent seizures, then we talk about putting you on medications or treating you for epilepsy.
Mm-hmm. And how is epilepsy diagnosed? It's just observation, but is there testing involved?
It's largely a clinical diagnosis with a lot of testing that will help support us. And basically, we get a clinical history of an event that sounds like a seizure. A patient comes in, has a period of either unresponsiveness or a loss of time. They may have certain behavioral characteristics such as lip smacking or staring blankly on there. Or if they have a full convulsive seizure, they might bite their tongue or have urinary or fecal incontinence. Afterwards, they tend to feel very tired and exhausted. So that gives us a suspicion that this might be a seizure. And then what we do is we do a variety of tests, one of which is the EEG. So an EEG is an electroencephalogram, and that's where we record from multiple points around the scalp. And we look at electrical patterns that would tell us that are suggestive that you have a high probability of having a seizure from either all of your brain or part of your brain. And then we do imaging, such as MRI, CT scans. We also do something called a SPECT scan. All these different ways of looking at the brain to see if there's any focal abnormalities that could be causing the seizure. This allows us down the line, if we need to, if you have a focal lesion such as a tumor, we might be able to remove the tumor and stop the seizures. If you have a scar from early childhood of something you did in your brain, if you had febrile seizures when you were young and you could develop what's called mesothelial sclerosis, sometimes those are amenable to surgical treatment. So we want to find out, if you have a lesion that would give rise to seizure, we want to find out if you have electrical pattern that suggests you have a high probability of recurrent seizures. At that point, based on the clinical suspicion, as well as the objective data we get, then we decide whether we're going to treat you with medications.
So Michelle asked, do people usually get diagnosed early in life, or can symptoms start showing up later in life as well? They're pediatric seizures.
That's a very good question. The incidence of epilepsy, as I said, is about 1 in 100, but it does have peaks. And so early in life, the highest incidence of epilepsy is in young children, actually the first year of life. And then it kind of goes down, but it stays around 1% for the majority of adults through adulthood. And then around age 65, it starts to increase, so that by the time you're 85, the incidence is around 3%. And that's because we're accruing insults to the brain as time goes on. So people might have had a traumatic injury to their brain, might have a small stroke, might be developing dementia or something of that like. So they can start at any time. As I said, most commonly, epilepsy begins in early childhood, but it can occur at any time in life.
Is epilepsy, is there an inherited factor, or can genetics play a risk?
So there are many genetic epilepsies. We think it's multifactorial, meaning more than one gene is involved, but it absolutely is inherited. Okay. But there's also an equal amount of sporadic patients, right?
Yeah. Megan asked, what can someone do to manage epilepsy?
Right. So the mainstay of treatment is medications. So we have a variety of medications. We have at least 12 available right now. That each medication has different efficacies, which means how well it treats different types of seizures, as well as has side effects. And so we kind of tailor it to the patient, which medication would work best. We do a lot of lifestyle things. So someone who has epilepsy, we encourage them to get good sleep, to avoid alcohol if they can. Alcohol can lower the seizure threshold for people with epilepsy on there, to decrease stress if possible. There are certain dietary ways of treating epilepsy. So at Johns Hopkins, there's a ketogenic diet center there. Usually for people with very, very significant epilepsy who have frequent seizures and are failing medications, that's kind of an option that people will try on there. In addition to the stress reduction, so take the medications, and then for people who remain refractory, if you take everyone with epilepsy, about half of them will respond to the first drug that we put them on. So you can go seizure-free and be well controlled with a single drug. If we take everybody with multiple trials of drugs, overall, we get approximately 70% or so will stop having seizures, but that still leaves 30%. If we kind of look at it across the country, in the United States of America, there's 370 million people or something, like 3.7 million people have epilepsy, and about a third of them we can't control with just medications. And for them, we work up, and there's other ways of treating. So we will use devices. There's something called a vagal nerve stimulator that we do put in here. There's a new device called a responsive nerve stimulator where you actually put it in the brain and it records the seizures and tries to stop them as they're occurring. We do epilepsy surgery, as we mentioned. For those people, if we can find the lesion, we can remove the lesion. Sometimes we can decrease their seizures.
And for each person, is the misfiring going in a different part of the brain, or how do you do the EEG?
So for each person, usually you have a stereotypical pattern of where the seizure is coming from. So the most common in adults is the left or right temporal lobes. We'll have the seizure foci there, but people have frontal lobe epilepsy or other areas. And it depends for each individual patient, but once you find out where it's going, that tends to be the pattern for this. So some people have multifocal epilepsy where the seizures do come from more than one area. Some people have bitemporal epilepsy. It's where you can actually have seizures from either temporal lobe. And then lastly, there's a large category of patients with what's called primary generalized epilepsy. And these are epilepsies that are most likely genetic, right? And they're really circuit problems, if you're network problems, where there's a lowered threshold for seizures, and when the seizure starts, it doesn't start in any one area. It kind of starts all over the brain all at once. And so these are different types of seizures, and so they will respond differently to different types of medications. So we kind of tailor our treatments to what type of seizure you have.
Someone is saying, if you have a seizure, how long after is it safe to drive?
That's a good question. I'm actually on the board of the MBA, and so the state of Maryland, it varies from state to state, right? The regulations are that epilepsy is a reportable condition, seizures are a reportable condition, and actually unexplained loss of consciousness while we're working up is a reportable condition. And in general, you can't drive until the MBA says you can drive. And this is the state of Maryland law. It is 3 months. Having said that, it isn't exactly 3 months. It's 3 months is the minimum. It can be, there's a board of, we call medical advisory board. The medical advisory board can recommend different times. We think it's somebody who's very difficult to control, and we're a little worried we might make the period longer. If it gets explained why you have the seizure and there's a medical explanation, we may not require you to not drive. We actually don't, the physicians don't decide, we just make recommendations. The privilege to drive, and it is a privilege, is given by the administrative side or the regulatory side of the MBA. And so it's actually when they say you can drive, you can drive. So your physician actually can't say to you whether you can or cannot drive. Only the MBA provides that. But in the state of Maryland, it's about 3 months for the first seizure. Right? And then you get paperwork, you take it to your physician, they fill it out, and then the board reviews it, and then the MBA notifies you. In practice, it's usually about 3 months plus a week or two while the paperwork has to go.
Just to remind everyone, you're watching Facebook Live. Today is National Epilepsy Awareness Day, and we're talking with Dr. Jay Foreman from the Sandra and Malcolm Berman Brain and Spine Institute. If you have a question for Dr. Foreman, please post it in the comments section. So can you walk us through what would happen when a patient had a seizure and then comes here to the Berman Brain and Spine Institute? What would be happening today?
So in general, we see you for the first time, and we're going to interview you. We're going to get a good history. We're going to look at your family history, what medications you're on. Were you taking any substances around that time? We're going to kind of set up and look for risk factors for seizures versus risk factors for epilepsy. And what I mean by the difference is seizures, a seizure is this electrical discharge, but has many causes. If somebody's salt is lowered, they can have that if they try to do medications, say tramadol, and that would be called, or Wellbutrin would be called a provoked seizure. We try to tease out whether this was a provoked seizure or an unprovoked seizure. And then if it's unprovoked, we try to figure out what's your risk that you're going to have another seizure, right? So we'll examine you, look for any focal findings on your exam, meaning do you have signs that maybe some part of your brain isn't working quite correctly. And then once we get all this information, we'll order some tests. And I said we'll order typically an MRI, a very special kind of, it's called an epilepsy protocol, as well as we'll do what's called a prolonged EEG. We'll often do what's called a sleep-deprived EEG, because when patients are sleep-deprived, when they transition between wakeful and sleep states, we're more likely to see an abnormality. And I'm going to take a step just to explain what the EEG, how the EEG works. Is the EEG is kind of like if you were to take 28 people and go around the Ford factory and put everybody's ear against equally spaced around there and tried to figure out what's going on inside. You wouldn't be able to, because you'd be listening to the activities of millions of different things going on. But if you did this for many years and you had someone inside telling you, okay, this is when they're painting the cars, this is when they're putting the transmission in, soon you start to recognize certain patterns of sound. That's what we do with electricity. So we have these electrodes all around your head, and they're equally spaced in a way that the same spaces on each person's head are roughly in the same place. And then we look at these electrical patterns, and over the last 100 years, we've established which patterns are more likely to be associated with a seizure versus other conditions. And so this is very predictive. If we see an abnormality from the EEG that is what we call epileptiform, then we come back to say you have a high probability of having another seizure if we don't treat you and we think you should be on medications. So that's kind of how the first workup would be. And then we do medication trials. We have patients keep a seizure diary. We kind of review with them what's the risk and benefits of the medications. And then patients, we also get labs and stuff like that. And then we see you again relatively quickly after we start showing the medicine to make sure you're not having any problems with it. And then after that, it depends on your clinical course, what we're going to do.
We talked about driving a little bit, but how else can epilepsy affect someone's life? People work or go to school.
So that's a very good question. So epilepsy, the biggest problem, most people are normal. All right. So between the seizures, they should be able to conduct a normal life and go on. One of the problems is driving. So once you can't drive in a city like Baltimore, where there is really not great mass transportation, it can affect your ability to go to work. It can affect your ability to go to school. It can affect your ability to have a normal social life with friends. In addition, epilepsy is recognized as a disability, but there are certain criteria how frequent your seizures are, how disabling the seizures are, and just because you've been diagnosed with epilepsy, they're not going to give you disability right off the bat. You have to show that you are disabled from the seizures. And so for a lot of people, the problem is that employers, once they find out you have seizures, do not want you working there because they're concerned with safety. It's actually been looked at, and patients with epilepsy aren't a major safety risk, but nonetheless, employers don't want to take on the insurance risk of the medical care need and the idea that you would have to be given time off if you have a seizure. So it's a big problem from the employment point of view. But and the fact is, most patients can work. Most patients can do their jobs perfectly fine, but you have to convince the employer of it.
Is there for some patients some anxiety? Am I going to have another seizure?
So
do you work with that? With their services?
So patients, it's very anxiety provoking. You don't know, one, am I going to have another seizure? Also, let them know, did I have a seizure, or was whatever I just felt a little seizure? And so it can be very anxiety provoking. In addition, it's highly associated with depression. Patients who have it often get depressed. We will treat them. If it's mild, we'll treat them. We'll refer them to a psychiatrist if it's more severe. Some of our medications can provoke depression in patients. Some can provoke anxiety. And to make things more complicated, certain types of epilepsy, one of the symptoms is anxiety. So it becomes a difficult problem to tease out. I think someone asked, do any of the patients...
seizure response dogs.
Yes. I don't have any patients who do. Some people do use them. But I don't have a lot that really do. There is a big trial going on worldwide to see how people respond how their seizure response will affect their ability to conduct.
The dog senses the seizure.
That's the idea. That's the idea. Yes, and there are some people that swear by it. But I'm really not that much of an expert at that, I can tell you.
And someone asked about getting more sleep. You mentioned lack of sleep could trigger seizures.
So getting good rest, you don't, and avoiding certain foods. If you have, one thing we do is we have people keep a diary of their seizures because it's not just foods. There are certain situations or things that might provoke seizures, and there's types of seizures we call reflex epilepsies, where a certain situation will actually stimulate or cause the seizure to occur. So we try to find that. But there's no specific food I'm aware of that reduces the seizure threshold. Alcohol, on the other hand, is a problem, especially after you've been drinking. As the alcohol is leaving your body, alcohol works on a certain receptor in the brain, and when the alcohol leaves, it increases the likelihood that you could have a seizure.
And so you mentioned maybe psychiatry, maybe but other services, is there physical therapy? What other specialists work with you on the epilepsy?
So we work with, the ones we primarily work with, not physical therapy too much because this is really a disease of electrical activity in the brain. Obviously, if you have a stroke that led to your seizures, we'll have you go through rehabilitation and stuff like that. Most often the groups we work with are neuropsychology, behavioral health psychology. We are fortunate here that we have a very strong neuropsychology group and behavioral health psychology, and what they do is work with people at one. So behavioral health psychologist works with them at learning to adapt to their lifestyle and adapt to having seizures. So it's more with counseling and treatment. In addition, there are certain types of seizure disorder that aren't electrical, which we call psychogenic seizures. And the behavioral health psychologist works with them to kind of manage these symptoms and get control of their life. Neuropsychology works with us in the evaluation and treatment of the seizures because a lot of these patients have memory issues. When we're working them up for surgery, we are dependent on neuropsychologists to give us a good assessment of how their brain's functioning, so that we can one, tell what side of the brain that their speech is coming from, their memory works from, but also make a reasonable assessment of risk to the patient if we were to do surgery.
We're just about out of time. What would you say to a patient who has just been diagnosed with new onset seizure disorder?
So I tell them first off that this is a treatable disease. That for most patients we should be able to control their seizures. It does require a lifestyle change, in the sense that you're going to have to take a medication reliably. The number one reason that patients fail treatment is because they don't take their medicines. And especially in younger patients, it's very hard. Some of these medicines have to be taken multiple times a day. So we strive to get them to either on a medicine that's once a day or to have a very structured way of taking their medicine, such as putting it right by their toothbrush, so they take it when they go to bed and when they get up in the morning. I tell them that that this is treatable. They should be able to live a perfectly normal life, and they should be able to go about and do everything they were doing before. They're just going to have to be a little more structured.
All right. Well, that's all the time we have. Thanks to Dr. Foreman from the Sandra and Malcolm Berman Brain and Spine Institute. If you want to learn about the team here and the services offered, please visit our website, which is lifebridgehealth.org/BSI. Please like us on Facebook and Instagram, and we'll see you next time on our next Facebook Live interview.